All right, let's dive into a big one in traumatology, fractures of the proximal humerus. We're going to break down how we classify them, figure out when to operate, and what really guides our decisions in the clinic.
So, why should you really care about this particular fracture? Well, it's all about the numbers. These injuries are actually the third most common fracture type you're going to encounter. That means you are absolutely going to see these in your clinical practice, so having a solid grasp on them is essential.
Here's how we're going to break it all down today. First, we'll tackle the classification system that really forms the basis of our decisions. Then, we'll look at both conservative and operative treatments. And finally, we'll wrap it all up with the key take-home messages you need to remember.
Okay, let's start with the cornerstone here, the Neer classification. You've got to know this system because it's the anatomical roadmap that dictates our entire treatment strategy. It's that important. So what's the core idea? The Neer classification isn't just about counting how many fracture lines you see. It's all about displacement. It organizes the injury based on how many of 4 key anatomical parts have moved significantly out of place. And what are those 4 key segments? Well, we're talking about the humeral head, the humeral shaft, the greater tuberosity, and the lesser tuberosity. The relationship between these 4 players is what really tells us how severe the fracture is. And this is where it gets really specific. Displacement isn't just a vague idea here. For a piece to count as a separate part, it has to be separated by more than 1 centimeter or tilted more than 45 degrees. These numbers are the hard and fast rules that drive the whole classification. So, this brings us to the real clinical question, doesn't it? Once we've used Neer to classify the fracture based on those displaced parts, what do we actually do? What determines which path we take for treatment? Well, the first path we can take is conservative or non-operative management. This is the go-to choice for those fractures where the bone's alignment is still pretty much intact. So for fractures that are non-displaced or just barely displaced, what the Neer system would call a one-part fracture, the goal is really simple: immobilization. We typically do this with an orthosis, a sling, or maybe a hanging cast. The idea is to let the bone heal on its own, no surgery needed. But what happens when the injury is a lot messier? That's our cue to pivot to operative treatment. The main reason to go to the OR is significant displacement and fragmentation. Situations where just putting someone in a sling would lead to a really poor outcome. And here's that decision point laid out nice and clear. On one side, you've got conservative care for stable, non-displaced fractures. On the other, you have surgery, which is necessary for those displaced, multi-fragmentary fractures that need to be put back together and held in place. See, it all comes back to displacement. Now, once we've decided to operate, we have a whole toolbox to choose from. For simpler breaks, like a tuberosity getting pulled off, we might just use some cannulated screws or a tension band wire. But for the really complex stuff, involving the head and shaft, we bring out the heavy hitters, like intramedullary nails or locking plates, like the PHILOS plate. Okay, let's compare the 2 workhorses here, the nail and the plate. The Proximal Humeral Nail, or PHN, lets us use a less invasive approach, which is great for the surrounding soft tissues, but it's really best for simpler 2- or 3-part fractures. The PHILOS locking plate, on the other hand, gives us much more rigid fixation for those really complex, shattered fractures, but it comes at a price. It requires a much bigger surgical incision, and that carries a serious risk of damaging the blood supply to the humeral head, which can lead to avascular necrosis. That's a huge trade-off that surgeons have to think about every single time. So what if the fracture is just too severe for fixation to work? Or what if a previous surgery has already failed? That's when we start talking about arthroplasty. A joint replacement can be the primary treatment right from the start for really bad fractures, especially in older patients. Or it can be our salvage option when a fixation fails to heal or runs into complications like necrosis. Okay, we've covered a lot of ground, from classification all the way to joint replacement. Let's boil this all down to the most important high-yield points that you absolutely need to remember. First, don't forget how common these are. They're the 3rd most frequent fracture. Second, the Neer classification is all about the displacement of those 4 key parts. Third, when you're thinking about surgery, always remember the big trade-off. The PHILOS plate gives you incredible stability, but it comes with that real risk of avascular necrosis. And finally, keep arthroplasty in your back pocket as either a primary option for the worst cases or a salvage procedure when things go wrong. So let's end with a clinical thought exercise that really puts this all together. You're looking at a complex, displaced, 3-part proximal humerus fracture. How do you weigh the biomechanical need for a rock-solid fix against the biological need to preserve that bone's precious blood supply? This tension, right here, between stability and biology, that's at the very heart of modern fracture surgery.